your patients? Have you run into any issues with insurance access or cost being an issue? How have those types of conversations gone?
Yeah, so I mean, cost is actually a legitimate concern here, and for a number of reasons. And these chronic progressive diseases is kind of really measured well by quality adjusted life years, and I think that when you look at GA as this kind of profound functional impairment that causes reading decline and it keeps them from sometimes it will stop them from driving, increases their fall risk, and causes more dependence on caretakers. If we can delay central involvement even by a year or year and a half as some of the modeling is showing, then the economic value of the patients in the healthcare system is actually substantial there. We routinely accept kind of far higher cost per quality adjusted life year thresholds for diseases with much less functional burden than GA. But I think the problem here is more so with our current infrastructure when it comes to Medicare without a secondary, Medicare Advantage and Medicare without a secondary patients. Both of these drugs are expensive, and their out-of-pocket costs for a patient who only has 80% coverage with Medicare Advantage or just with Medicare Part B on its own is going to cost them, it's going to cost them close to about $400 for one eye, maybe $450 in one eye. And if they do both eyes, obviously we're talking about close to $900 if they do not have a secondary insurance. And so we used to be able to make up for this with Good Days. The Good Days being this, extra, not associated with the government kind of entity that we can sign the patients up for, that is a nonprofit and actually provides additional help financially for coverage for that extra 20% that's not covered usually by Medicare Advantage or Medicare. But in recent years, as most people have known, Good Days has run out of money very quickly, and we don't have access to it for a large majority of our patients. And so it has been much more difficult to even offer this therapy for patients who are on Medicare Advantage plans currently, who we know will be unlikely to maybe afford paying $800 to $900 every 1 to 2 months for therapy with this. And so some good news very recently is that the Good Days program has now been split so that there is a separate pool of just therapy for the non-vascular retinal diseases, such as GA, along with now MACTEL, which is actually still vascular, but they keep it separate from, say, the bigger high dollar treatments like that are for wet AMD and DME coverage for that. So that may help because now the companies that support pegcetacoplan, the companies that support Izervay as well, they can actually just pool their funds into a separate kind of pot that can be used just for GA patients. And that has helped to at least get some additional coverage for some of our GA patients that weren't getting access to anything from Good Days before. But it's rolling and slow. And so I still have patients who are kind of waiting to see if they can get approved by Good Days with this separate NDRD Good Days account that is still kind of ramping up right now. But hopefully in the year we can get more coverage and get more assistance for the patients who need to get these drugs.
Certainly, those additional funding sources you mentioned can help people a lot in getting access to these drugs. I mean, it's just for the sake of conversation. If someone does not have access to that and they're asking you, do you really think this is worth it? It's going to be at least, maybe several years before I have a theoretical benefit from this, and we're not sure that, even if I am on the treatment for that amount of time, that it's actually working for me, even though for, the group, it might show some evidence. So how do you talk about it with that person who's really trying to ask you, like, is it worth it for me?
Yeah, I mean, I don't think that I'm not even offering it. I'm telling them people that it's probably not worth your money and time if you are having to pay, close to $900 if it's for both eyes every month or 2 months. I think it's not sustainable unless they're, a millionaire person who wants to spend their money that way and I usually will just say it's not worth it for us to proceed. Now, I will start actually enrolling them if they are interested in the Good Days program now, and if they do get approval, then I will allow them to I'll try to get them on a treatment plan from there. But I won't say it's actually worth it for them to be spending that amount of money on this treatment at this point in time if they do not have coverage.
We hit some interesting points. We talked a bit about the most recent data, some of the encouraging anatomic results. I think, personally, I think the functional results are still, I'm hoping to see more data on the functional results that would show that it has a benefit for people's independence or, reading or function, driving, whatever it may be. Some additional functional outcome I would very much like to see. And we went through some of the efficacy, side effects, cost considerations. Any other closing thoughts that you might have?
Yeah, I mean, I think I'd say that, the key message for GA is that at least it's no longer a hopeless disease for us. I think there's at least we have something now to offer our patients. And, obviously, we're still in early days when it comes to treating this disease, but it was one of these things that I was frustrated with as earlier on as a clinician with these patients, where I just felt completely helpless, and it's not a great feeling as a patient, not a great feeling as a physician as well, to just say, well, sorry, it's just going to keep getting worse, and I can't do anything for you. At least now we have some hope. For one thing, to get the ball rolling here, and this is not going to be, I'm hoping this will not be the treatment for patients as a standard of care 5, 7 years from now. And I do have a lot of hope with what's in the pipeline right now, but we have to wait till see how things pan out. But at least now we have something to offer, and it is, evidence-based in terms of not as much in terms of functional visual outcomes as you said, but more so at least in terms of anatomic outcomes. We do have something to offer them. It's not perfect. It's kind of like our first generation anti-VEGFs, maybe kind of like even Macugen, but when we first started treating our vascular disease with that. But we've come a long way with our anti-VEGFs and the other treatments that we have now for our vascular diseases. And I think we're going to come a long way with GA, but at least we've gotten the ball rolling here. We can offer something for our patients.
Yeah, I mean it's a place to start. Definitely looking forward to more data on these existing drugs and more to come. So thanks so much, Ash, and we'll talk again soon.
Appreciate it. Thanks, Joe.